You're all very welcome to the Association of Physicians regular webinar series. The Association of Physicians of Great Britain and Ireland is the leading medical academic society in these islands, and we hold regular webinars because one of our core remits is medical education, and these are monthly webinars. And as you're aware, this webinar this afternoon is on the long COVID syndrome. We have two eminent speakers who will discuss patient stratification and the disability that is long COVID. And we'll also have a state-of-the-art speaker on current trials and therapies and potential future therapies in the context of the long COVID syndrome. In relation to, after the two speakers, we'll revert to a Q&A session. And in the context of you, the viewers, if you could type into the Q&A button at the bottom of your screen any relevant questions that you have, and then Charlotte Summers who will be co-chairing and will coordinate the Q&A session, the second half of this webinar. Our two eminent speakers, the first speaker will be Dr. Anuradhaa Subramanian, and she's from the University of Birmingham, specifically from the Institute of Applied Health and Research. And she and her colleagues are at the forefront of stratifying patient stratification in relation to prognosis in the long COVID syndrome, and ultimately guiding future therapies in the long COVID syndrome. And the second speaker will be Professor Charlotte Summers. And Charlotte is Professor of Intensive Care Medicine at the University of Cambridge. She's also Director of the Clinical Academic Training Programme at the University of Cambridge. And she's going to be talking in the context of therapies currently and future to improve the disease that is the long COVID syndrome. So without further ado, I'd like to welcome our first speaker, Anuradhaa Subramanian. Anu, you're very welcome. And if you'd like to take up the screen and load up your presentation.
Thank you. Thank you very much, Professor Shamus. Good evening, everyone. So I'm Anuradhaa Subramanian. Thank you so much for the introduction from Institute of Applied Health Research, University of Birmingham. And I'm here today to discuss the key findings from the Therapies for Long COVID, or the TLC study funded by NIHR. I will be presenting today the findings from a large-scale observational study in specific that I was a lead author on, exploring the symptoms and risk factors for long COVID, especially among non-hospitalized adults. The primary aim of the study was to assess the association between confirmed SARS-CoV-2 infection and a comprehensive range of symptoms from various domains reported by patients to the primary care physicians in the acute, ongoing, and long-term or post-COVID-19 phase. We also then went on to assess the risk factors for persistent symptoms post-COVID-19. Finally, we explored how the symptoms cluster together to explore latent clinical phenotypes of this heterogeneous long COVID condition. We also then characterized patients who belonged to different symptom-based long COVID phenotypes. So for this, we undertook a retrospective matched cohort study between 31st of January 2020 and 15th of April 2021, using data from a large UK primary care-based electronic health records called CPRD ORUM. The infected cohort was defined as patients with a coded diagnosis for COVID-19 within their primary care records, without a record of hospitalization within 28 days of infection. For each infected patient, we then went on to obtain a pool of eligible uninfected patients without a record of suspected or confirmed COVID-19. Each infected patient was then propensity score matched with up to 4 uninfected patients using a logistic regression model, including a comprehensive range of covariates like age, sex, BMI, socioeconomic deprivation, smoking status, ethnicity, and a wide range of comorbidities and even symptoms that were recorded 12 months prior to the index date, that is at baseline. A total of over 400,000 non-hospitalized individuals with SARS-CoV-2 infection were identified, and they were propensity score matched with up to 1.9 million uninfected patients. Kernel density plot on the right-hand side of the propensity scores for the infected and the uninfected cohort before and after matching suggests that the two cohorts were actually well balanced post-propensity score matching. In terms of the symptom outcomes, a symptom burden questionnaire for long COVID was developed following review of existing patient-reported outcome measures when the existing symptom coverage was actually insufficient at the moment. Following the conceptual framework and rash analysis, a final set of 115 symptoms spanning 15 domains were identified and were explored in this retrospective cohort study. At 12 weeks after index date, 62 of the 115 symptoms were significantly associated with COVID-19 in the longer term. Notably, these 62 symptoms spanned across 14 different domains, ranging from fatigue, pain, respiratory, mental health, cardiovascular, gastrointestinal, and sexual health symptom domains. The word cloud here sort of represents these symptoms, and the font size within these word cloud is proportional to the strength of their association with the history of exposure to SARS-CoV-2 infection. Loss of smell, hair loss, sneezing, loss of libido, shortness of breath, and fatigue were some of the symptoms that were relatively reported more commonly in the longer term among patients exposed to SARS-CoV-2 compared to uninfected patients. We also considered two composite outcomes, the first one being the reporting of any one of the symptoms that were acknowledged in the WHO definition for long COVID. And the second outcome was defined post-hoc as at least one of the 62 significantly associated symptoms that were reported in the long term. Both of them were significantly associated with COVID-19, and they were reported at 26% and 29% increased hazard at an increased rate among patients exposed to SARS-CoV-2. In the risk factor analysis, we found patients at a younger age, women, patients from Black, Asian, and other ethnic minority background, patients who were socioeconomically deprived, patients with high BMI, and patients with a pre-existing comorbidity were at a higher risk of reporting symptoms that were persistent. We performed a latent class analysis among patients who reported persistent symptoms. We found that the three-class model had an optimal fit. The first class constituted 80% of the patients, and this class included patients reporting a broad spectrum of symptoms. Class 2 constituted patients reporting respiratory symptoms specifically, such as cough, shortness of breath, and phlegm production and excess. And finally, class 3 included 14% of the patients who had mental health symptoms such as anxiety and depression, along with insomnia and brain fog. When we characterized these phenotypes compared to patients who did not report any persistent symptoms, patients in all the three classes were more likely to be women, were more likely to be deprived, were more likely to have a smoking history. With respect to age, patients belonging to class 3, that is, patients who were dominated by mental health related symptoms, were more likely to be younger. With respect to ethnicity, patients in class 1, dominated by a broad spectrum of symptoms, were more likely to be from Asian or other ethnic minority group. We were fortunate to have patient partners who were closely involved in the design and dissemination of the study. As next steps, we are working towards exploring the underpinning pathophysiology using biomarkers across the different phenotypes and exploring the incident autoimmune disease risk among patients with a history of COVID-19 exposure, and also the potential economic impact of COVID-19 in the longer term. Thank you all so much for listening, and I'm very happy to take on questions at the end. Thank you.